Great. Welcome back, everyone, to the House Healthcare Committee. We're going to continue our conversation on the budget. Representative Cordes is joining us now in the Zoom world. So thank you, Mari. Just pipe up if you want to say anything. Okay, so we're going to go to the one-time funds. Again, these are one-time, does not increase the base. And moving one time, saying we don't want to do something in one time does not really help us get what we want in the other items, which are the base, right? Because the base, something we put in ongoing year after year after year until it gets taken out. One-time money is one-time money. So we can say we don't want to do it, or we could take some one-time money and give it to some other one-time money. But it's more difficult to say, well, we're going to take one-time money and put it into base, which I know Alyssa doesn't agree with because we had a discussion last night, but so we can get to that when we get to that section. So let's start with Blueprint. So Blueprint has three components to it. 2-year pilot with 3 components. One is Dulce. So this helps infants and their families. One is increasing the per member per something rate that community health teams get. Community health teams are based, and if I say anything wrong, anyone in the audience can help. So community health teams are at primary care practices. I believe they're also at FQHCs sometimes. And they help primary care providers by being able to do more whole person work. So someone's here, I can just give an example. Someone's seeing a primary care provider and I have diabetes and my primary care provider is suggesting that I see a nutritionist. Or I have diabetes and I'm homeless, so I have nowhere to keep my insulin. So instead of a primary care provider taking the time to figure out what to do, or simply saying to me, okay, well, here's a referral to a nutritionist, let's say. I could be given to a community health team member there in the office or soon after who could help me get the services I need, right? And so the thought is, and I think we got some data that shows some studies that providing that care through community health teams is preventative medicine. So it's the Dulce, it's that, and then it's increasing services at our hubs where people are going for treatment who may also have some type of co-occurring issue. And potentially, instead of them being told to go to a primary care provider, they could do something with them at the hub. It's one-time money. It's a 2-year pilot. And although there is some concern from Vermont Care Partners about staffing and duplication within the DAs, we did not really hear anyone speak against it. So, what does everyone think about Blueprint?
Can I ask just a question about what you just said? In the Dulce program, I missed that. It's infants of 0 to 6 months of families who have substance abuse issues, or all families?
I think it's all families. Hold on.
All families.
Yeah, I was reading.
Yes, all families.
Thank you.
Where exactly are we here?
We're in the one-time funds, the very last couple of rows.
Last, okay.
Yeah.
Alyssa?
I'm fully in support of this. However, is there language we can insert, kind of like we did last year in 167, to have them come back with rate increases on the per member per month that actually goes directly to primary care?
Yep. So,
Say that again, I'm sorry.
So last year, we tasked them with coming back with rate increases on the per member per month to the community health teams, which is what they did.
Commercial or,
so remember, community health teams get paid by Medicaid and they get paid by commercial. And so this proposal is only increasing the payment by Medicaid for the 2-year study. So Alyssa's saying at the end, which I think they're gonna do anyway, but we can put it in, at the end of the 2-year studies, no, this is not what
This
you're
is
saying.
not what I'm saying.
Okay. Okay, but okay. keep
So the
going.
blueprint is made up of 2 pieces. There's a per member per month that goes to the community
Oh,
health
okay.
teams.
Yeah.
And then there's a per member per month that goes directly to a primary care provider for their attributed lives.
Yep.
And so last year, we asked them to look at increasing the per member per month to the community health teams, and that's what they came back with us this year. But I'd like to insert language that they will come back to us next year with increases to the per member per month that goes directly to a primary care provider.
So if you, Leslie and Art, last year, our language in 167 was exactly what Alyssa said. We should have been more broad in that language. We said just community health teams, but really there's also a primary care component of Blueprint. So this would just require them to come back and say how much an increase would be, which I think is appropriate. And then if we keep this in, which I also advocate that we do, I'd like to add language that requires a report back in January on the status of the project, of the Blueprint 2-year program.
If we're gonna ask for a report back, I'm really concerned about the long-term survival of the Blueprint because of the payer mix that goes into Blueprint.
Okay.
So Blueprint is only, remember, the only entities that pay into Blueprint are Medicare, Medicaid, Blue Cross Blue Shield, and MVP. And I believe Cigna has a tiny component, but you know, that whole self-insured slice of the pie that we have, none of those pay into Blueprint. And as far as Medicare goes, you know, Medicare is now made up of traditional Medicare, which is still paying into the Blueprint, but it's also made up of now Medicare Advantage plans. And our proportion in the state of people leaving traditional Medicare and going into Medicare Advantage plans is growing every year more and more. And the Medicare Advantage plans also do not pay into Blueprint. So every year, the pool of people that are paying into the Blueprint gets smaller and smaller. And yet all the services, the community health teams, the per member per month for providers, all of that goes to support the whole. So does that make sense?
So here's my question though, to Ledge Council or JFO. Do we have the capability to direct Medicare, Medicare Advantage, or self-insured plans to participate in Blueprint? Do you know
So
that?
Jennifer Farragut, Legislative Council. I think there may be some yeses and some nos. Medicare, I think they have agreed to as part of our all-payer model.
Yes.
Medicare Advantage is maybe beyond our ability to reach the, I think Noel's looking into the self-funded ones there. Based on the language that's currently in the statute, they potentially should be paying in. I don't know if they are, but there's also the potential for some preemption.
Okay.
I would say it's an unclear legal landscape about where preemption fits in when you're looking at patients, because it's not as specifically about benefits being provided. So
Could
maybe.
Okay, so could we draft language to ask them to come back with an analysis of could they be, and if they could?
I think it would be helpful to know from the outset who is paying in and who is not.
They probably know. You
Right.
can probably talk to them, and they can tell you exactly who's paying it. And also what I've asked is whether Blue Cross Blue Shield, who pays any into Blueprint on behalf of their TPA business.
Okay.
Can you say that again?
So I asked
That's
if,
really the question.
I asked if like I asked Blue Cross Blue Shield to tell us if they're paying in the Blueprint on behalf of the lives under their third-party administrator, which are self-insured.
Right, and I think that would be
Okay.
the nexus that we would be
Okay.
connecting, because those who are actually administering, employers who are administering their own
Right.
plans internally, I don't think we have any
Right.
regulatory authority over.
Okay, so I would probably say that can be a conversation we can have outside of budget. Let's, so, with
Yeah, I just
Blueprint.
thought if we were gonna get a report back.
Okay.
Can I ask for a clarification on your report back, Blueprint report back, or come back with increases to the per member per month directly to the primary care providers?
Yes.
In Act 167 language, you had them reporting on the amount of the PMPM, how much it should increase for the shared costs of operating community health teams and providing quality improvement facilitation, and it talks about furtherance of the goal, providing comprehensive primary care services. Is that the kind of language you want to tie it to again, or is there something, you're asking them to come back with an amount that the PMPM should be increased, but I'm not sure what they would be basing that on.
Can I look at the language of 167?
Okay, let's keep talking while they do that. We'll come back to the language. Okay, so anyone advocating to take Blueprint out?
I am.
Okay.
It's fine.
And this is the reason.
Okay,
You got $9 million in general funds you can spend. I think for this year, we need to pick the things we want to work on. And to me, it's Medicaid and it's mental health.
okay,
Facility in Northeast Kingdom being key to that. I think that if we get too spread out, that we won't focus on those things. So I haven't got anything in here for the one time.
Okay.
I really, other than termination,
so, right, and so that, I mean, that has to happen.
but I just feel that if we're ever gonna get a handle on the cost of healthcare, we've got to make some tough decisions, and this is one I make. I say we don't do this, but.
So I agree with you completely on your statement that we have to invest in Medicaid and mental health, and that's what Blueprint is doing. So Blueprint, although it's not Medicaid dollars, it will help.
Sure, I mean, it sounds great, but.
And then it's enhanced, so then the other thing it's looking to do is integrate mental health into primary care, so that if I go into my doctor
Yeah.
and we have a discussion and I talk about that I'm feeling a little depressed or something, instead of getting a referral to potentially a private therapist or someone, which you can't get into, I could be getting help right there in the primary care office. So yes, it's a lot of money. And my concern is that what happens at the end of 2 years? Hopefully they'll be back and we'll have the funds to keep it going because it's proven that it's helped mental health and primary care. But I think it's something that, personally, I think it's something that is meeting the values we're setting out amongst this committee of helping increase payments to providers to provide the care they need so that they don't close.
Well, just for me, for making a hard choice here, I say we take it out.
Okay.
It's just one guy.
All right, so all those in favor of keeping.
Can I make it?
Oh, sorry. All right, who else wants to say something? Okay, go ahead. No, you go.
I think that this is an important program, because it's really the only thing I'm seeing that really looks at social determinants of health and moving into places where people can learn to be healthier. Certainly the infant program does that, but also community health workers, which is a big investment, really learn a lot about the individuals in their practice, how they can help them be healthier and really save money down the road. And this is a long-term investment in keeping the population healthy. And having a healthier population will result in less cost down the line. So I think it's an upfront investment. Yes, it's a lot of money, but I think we need to think about how to keep our population healthy. And this is the only place I'm seeing in our budget that thinks about this as a population investment. So I'm for it.
Okay. Daisy?
Yeah, I agree that this is a place that, one, it's a forward-thinking proposal that attempts to get at social determinants of health in a way that incorporates integration of mental health and substance use care in ways that are really improving access across the state. I question how much stakeholder input went into this investment. It is a significant investment. And I think anybody that were writing a grant for this much money would have to put forward something that had a lot more stakeholder investment. I think if you're working with co-occurring disorders, you definitely need a lot more training for your clinicians and how to do that. For us in Winooski, we would want to see a lot more emphasis in community health workers. Probably since this is working with FQHCs, I think it's definitely caring for populations that need these services and access. And I think we heard from, my concern is that, you know, with workforce and staffing issues with the DAs, would this be taking the skill set away from those DAs? And I heard that there were actually already existing arrangements of referrals between them. So I support this. My one thing is, if we're going to be changing language, that we ask, you know, we might have an offline discussion that sort of asks them to do more investments in community health workers specifically. Because I see there's a really high UI component in this, and I think that's fantastic. But I also know that the Blueprint's been operating for 13, 14 years. And this is, you know, FQHCs have been around forever. I think we've studied the heck out of them. So I think at this point we should be confident in what they do, and we should focus on the existing model, learning more about mental health and integration than anything. So I support it, as in short.
Okay, and so let's maybe talk offline about what you would want to put in for language, but give me an idea of, so you're saying some of the money be diverted.
Focus on community health workers.
Rather than the hub. So there's,
Yeah,
say there's the hub, there's community health teams. In what order do you want the focus to be?
Can we talk offline?
Yeah. Okay. Anyone else on the? You don't have to say anything, we just vote.
Well, no, okay, I've got a question.
Yep.
Okay. So you said we gotta prioritize. Now, you said 2, 3, 4.
So we're gonna prioritize. So we have one more thing to talk about after this. And then we're gonna, actually 2 more things. And then we're going to do high, medium,
And-
low.
In each one of these
In the whole
segments.
thing.
Okay, so.
And then the high, we're gonna go 1, 2, 3.
Okay, that's-
Okay. So anyone who's in favor of taking out the Blueprint pilot?
I have at this point, yeah.
Okay, so 2, who's in favor of keeping it in? Okay, so for now it's in. Okay,
Maury is
I'm
a,
raising my hand.
Oh, you didn't do it in time.
you can't vote.
Oh, that's right, I can't vote.
You can't vote, sorry, Mari.
But it's good to know you're with us in spirit.
Okay, so we're gonna address a couple big things, and then we're gonna skip some of the other one-time funding. It doesn't add up to much. We will come back to it, but I want us to get us to priority. So we have a $10 million ask, one-time money to address emergent and exigent circumstances impacting healthcare providers. This is what Secretary came in and talked about on Friday. Where this is a fund, we started it during COVID. And so people can apply, community agencies, can apply to say, you know, I'm having this impact from COVID. It could be workforce, it could be other things. And I'm applying for emergency funding.
I like that in concept. I don't like what feels like to me, lack of transparency and equity in the process by which folks get that money.
Okay.
I would want to see that there is alignment with, across the system with how folks get that and the way that they apply it so that it's actually having the intended impact.
Okay. So you're saying keep it in if we put some parameters around it.
No, I think we could redirect it actually. And bear in mind, I have been at the agency before. I have been part of this process of distributing similar funds. And I think we could use it in one of these other requests better.
Okay, so remember, we're not moving one-time money to base.
Got it.
I tried that.
Alyssa tried that. Alyssa.
Did we get a list of where they have used this money?
No.
And are there maybe somebody in the room can help us? Who is eligible for?
Does anyone in the room know?
We could ask,
I'm just wondering if this would be like the Springfield Hospital Rescue, is that kind of the idea?
No, this was, I don't think so. This was because of COVID.
Maybe
No, I know, but
workforce things.
Workforce things, skilled nursing, you know,
keep the doors open.
I'm sorry,
Sometimes.
That's what I mean about,
helping doors stay open, yes.
I mean, none of this is addressed by the bill we just passed out of committee, the COVID.
No, this is specific money that can be applied for, how do they have it listed here? Emergent and existing circumstances. Okay, I'm about to close my doors. I need $100,000 to stay open.
So if someone can't make payroll,
Right. Hopefully, can that get addressed by the Medicaid?
So potentially, we don't know because we haven't seen a list. Potentially, yes, it could help. If you remember, they have given out, and I forget what the dollar amount they started with. They've given out all but 4 million of it from the last time this was put in place, and they have about 16 million in requests.
and what was, do we remember, I don't remember what the initial fund was? You said they had 64.
And
20,000?
Is this the healthcare provider stabilization grant program or is it something?
No, this is different. Yeah,
There were a lot of parameters now.
I think it was about 25,000.
25 million.
25 million. I mean,
did we
They
see
said
that?
most of it's been allocated and they just want us to do more.
yeah. So I'm gonna pull up the
Basically, they wanted to meet the needs of the ones they've already have applied for.
right.
And they thought they could do that with
Yeah.
what was left over and this.
Yeah.
So this wouldn't go to anybody new.
Right.
Okay, so here's.
Oh, there you go.
Yeah.
So
Did they
25 million, general fund appropriated, they expended 21.1 million, there's 4.9 million remaining. 20% went to open up beds for skilled nursing. 44 went to supplement payments to hospitals. 24 went to provider emergency stabilization payments. 12 went to non-federally covered COVID recovery related expenditures. And they have about 16 million in funds in requests.
So the dish payment to hospitals came out of that?
No,
No,
Separate.
it's just different.
supplemental dish payments to hospitals.
So that,
Supplemental
yeah, the
to
supplement.
help them through some of their issues.
So that did come out of there.
And this is general funds, not
Right.
CRF ARPA.
Nope, this is general funds.
Can I just say, the reason that I immediately was like, no, I can push back on this is because I think it's really frustrating to see the administration putting more Band-Aids on our healthcare system. It's absolutely frustrating.
And
Like, we have been in crisis response mode for years. And I don't think anybody went to school to be a crisis responder, except those people who went into those professions. And here we are. And I'd like to see the administration putting forward proposals that actually help folks get upstream rather than putting on these Band-Aids year after year.
So I think we add that to our intent language of why we put forth this, what we're doing. We're tired of Band-Aids. We have to say it a lot nicer than that. But I don't think we should hurt.
Sorry.
That's okay. No, I'm just saying. But can I finish my statement? So, but I think we should not in the process because we are concerned that there is not a holistic view and we're not investing where we should. That's our concern, right? And there's Band-Aids being put in. We should not be hurting those who need those Band-Aids to stay open.
So Lori, how can we redirect this into areas that get upstream of that? I mean, I'm always talking about practice improvement, not that I think that providers need to improve that themselves. I want to see the administration directing that. Like, they're the ones that are like value-based care, which I get, I want for myself and for all of us, but like, how do we move a system toward that?
Right. I don't think we're going to do that in this $10 million. I think what we can do is say that we want more transparency. We want to understand where the money's going we want to report back on projects, and we want to understand how next budget we can be, whatever we want to say, but we're not going to
Better
do that with this
partners in
10 million. Yeah.
Mara has her hand up too.
No, I'm not sure. Mara, did you want to comment on this or do you still have your hand up from before?
No, I want to comment about this.
Okay, go ahead.
So I 100% agree with you, Representative Burbecko, about process and about how whether it's mental health, primary care, hospital systems, how we're continuing to try to fix the plane while it's crashing. And at the same time, I agree with Representative Houghton that we need to include this. Just remembering that adding new beds to skilled nursing, having any openings in the system are going to help unplug it and get people out of the hospital that are just sitting there because they don't have a skilled nursing facility to go to, or they don't have a long-term care facility to go to. And that is costing hospitals a lot more money. It's costing the system a lot more money. So I think that it's up to us as legislators to come up with systemic change and a very strong process by which we make an inclusive process by which we make these changes.
Thank you, Mari. Art or Leslie?
No, go ahead.
Well, I think there are two different things going on here. One is, I think how Lori refers to it as, the Band-Aid. I still think we need Band-Aids because our system is still really broken. And we do need some resources for, to act as our Band-Aids as hopefully we do what you want to do, which is a systemic evaluation of our whole system that we can then move in a much healthier direction. So I'm going to support the $10 million, but I do want a report, and I'm hoping by January, and I'd like that in the language, January of 24.
After that, Jen.
That will describe for us how this money's been used and the intent of it. I'm not sure if we want to add more parameters. I'm not sure I do because the system is so in flux and we don't know where this money might be needed. So, $10 million out of their $1 billion budget is really tiny. And I don't know how much it'll save, but it might save something.
Okay, thank you. Bobby?
Was I correct in understanding that this money's already almost spoken for? It's already been spent? They just.
Well, I mean, they haven't accepted it, but people have applied.
Yeah, so they have more than this much already waiting to go out.
Yeah.
Because I was gonna ask what's gonna happen if the fund doesn't get used, but doesn't seem that's even gonna be possible. Yeah.
Yeah.
Can I just clarify something maybe with Nolan? This is essentially it's residual money. It's
money that I think is dropped to the bottom line because of federal assistance that's freed up general fund. I think.
so, you know, for 3 years, 2.5 years, I don't know, however many quarters, we've been receiving this huge amount of money for the increase in our FMAP. None of it's gone to our base budget. This is money from that. We might as well use some of it for health-related reasons.
Yeah. Okay.
So,
Lori, do we know what parameters they have to show to get this money?
I know we talked about it with the secretary, but I honestly can't remember the testimony.
Yeah, I don't at all. I just wonder how they come up with 10 million exactly versus, I don't know.
Probably, when you put the whole
Yeah.
pieces together and they want to get to a final number, that was part of it.
And this money is for folks that, this circumstances caused by COVID that is putting stress on their organization to the point where it can close.
COVID, workforce issues, all of the above.
Yeah.
Inflation,
And we don't know which type of healthcare providers, it just says healthcare providers.
it does say in the slide deck, it says that, they're considering 16.5 million one-time proposals to improve flow and reduce pressure due to unmet mental health and long-term care needs.
I know some of this will go to helping the long-term
Nursing home.
care needs so that people who are sitting in the hospital who no longer need to be there can get to a bed in the best place they should be and alleviate some of the pressures on the hospitals. All right, everyone okay with leaving it in and we'll prioritize it?
Like it's already spent.
Yeah.
Those requested, not
What'd you
spent.
say, Lori?
Straw poll on leaving it in. Everyone in favor of leaving it in and we'll prioritize it. I know, we're not doing really well on getting anything out. I get that. But we're having a really good discussion and we will be
This is the
prioritizing.
lowest priority I have,
Okay.
is what we leave in.
Okay,
Here it is, here, supplement.
all right. We have to go back to Vermont Care Partners and FQHCs. So let's talk about Vermont Care Partners.
Okay, 23.
I am, our neighbors next door, in the other building, are also looking at a Vermont Care Partners increase for their piece of the puzzle, which comes out of Dale. And we try to sync together to ensure that increases are consistent across all. And I haven't gotten their final decision, but I think they are looking at 4%. So I'm gonna throw that out there. And can you tell us again what that is?
May I ask again?
Yeah.
Is the amount that we're considering in here, is that just for our piece and their
It's
piece
just
is
for our
separate?
piece and their
Okay.
piece is separate.
That was confusing me a little bit. All right. 4%.
6.2 gross and 2.9.
Well, that's assuming you give it to all different ones. Is-
No, and we can't hear
Yeah,
you.
we can't hear you.
So there's four different lines that the rate increases show up in the budget. It would be under VDA for substance use disorder, maybe, and there's like 3 lines in DMH, which I would just combine.
Yeah.
So,
So this is mental health and substance use disorder, which are often co-occurring diseases. So I say we don't separate it. We agree on a percent. A majority of it is going into DMH to increase rates to providers. So we're looking at 6.2 million gross, 2.9 million general fund at a 4% increase. Any thoughts?
I just wanted to correct the record that when I didn't list Vermont Care Partners as a priority, that was a mistake. It was just a mistake of omission. So,
I the same, Bob.
yeah.
It's hard, I know, it's hard to,
And I want to say that I didn't list them only because I didn't want 10%.
So you,
Okay.
well, that's the thing, you're gonna,
I
you
wanna,
want 4?
yeah, let's do that. All right, straw poll, who wants 4%? All right, who doesn't want 4%? All right, we're going with 4%. Sorry, Daisy. And I will confirm that that's what Human Services is doing too. Yeah. I just sent her a text. I know what people used to do when they didn't have electronics.
Those pages ran a lot.
Okay, so now we have to talk about FQHCs. So, because we haven't really talked about them. So FQHCs remember, they get paid differently, right? But they still are in communities working with Vermonters. They provide whole spectrum of care, primary care, mental health. They have community health teams. They are asking for rate increases of all funds 6.9 million and general funds 3 million. So we don't have the same nifty chart we just had with Vermont Care Partners that we could put in the percent increases and determine how that affects them because they really get paid differently. So I am open to suggestions on what we do about this and keeping it as is, reducing it. Thoughts?
Well, I'm sorry, which line are you on?
We're on the line, we're at the end of the non-governor recommend, right above VSAC, the bi-state FQHCs.
Oh, go ahead, Bob.
I'm sorry.
Yeah.
So am I the only one who gets their healthcare at FQHC?
No, I don't think so.
I do.
Yeah, okay, good. I just wanted to put that out there.
Yeah.
How are they different? I didn't understand when they came in. I didn't get.
We're gonna have Mary Kate's here. Do you mind?
Not at all, I'm happy. They provide much more services beyond what you typically
That's what
think
it
of
was.
as primary care, plus the mental health, plus substance use disorder, vision, dental.
All in one package.
Dental is a different payment methodology, so I don't want to get too confused. I just want to mention that they offer dental, and they're often the only
Gotcha.
game in town accepting Medicaid for dental. So this is, when you go in for your visit, any service that they provide, whether it's the mole removal, your diabetes care, your annual well visit, that's all one single rate.
Gotcha.
So can I ask, and this may not be something you can answer. So with the other ones, we can try to have a consistent methodology because it's a percent, increase.
Mhm.
So can you equate this request to a percent increase?
It works out to about a 20% increase on current rates. Now, that's the current rates and not tied to the cost. I just want to throw that out there.
Okay, which I get that, but no rates are meeting the cost of services for anyone in our system of care.
Can I add something?
Uh-huh.
Is it true that FQHCs also have to serve anyone who walks in the door and they have a service area that has to contain underserved populations?
Yes, they have.
So if another hospital gets built, you can't then come in and try to build an FQHC because that area is already served, or that population is already served by another provider.
I believe so, unless, but I'm a little more fuzzy on where, like, at the hospital, but yes, you have a certain area to be recognized as an FQHC, and receive, to be recognized, you have to serve a specific area. You have to take everyone regardless of whether they have insurance or not, and we have to participate in the Medicaid program. And we serve about 50% of Vermont Medicaid.
And you serve primary, substance use, and mental health.
Mhm.
And how many I'm sorry. That's right. But this, I think it's really important in understanding this investment because it's potentially a big investment. How many FQHCs are part of the Blueprint hub and spoke?
All.
All of them?
Yep.
Okay.
Free care.
Oh, yeah, free care. So uninsured, and anyone under 200% federal poverty is qualified for a sliding fee scale, and that could be 100% coverage, so you owe nothing. And that includes Medicare copayments. If you can't afford your Medicare copayment, we write it off as
These types of FQHC.
You go to community health, that's what.
Oh, okay, there we go. Okay, that's
Yep.
what you told me about. Okay, so that is that one of those organizations. So you probably see a higher level of Medicaid patients than most. Would you say that, or?
Yeah, we are fortunate in Vermont that we have such a high insured rate that we actually have we don't have such a disproportionately large Medicaid
Okay.
population, but we do see.
I'm just trying to get to.
Like I said, we serve half of Medicaid patients in Vermont.
Okay, so if you have to take anyone coming in.
Yep.
Okay.
Yep.
Thank you.
Can you explain how your federal payments play into everything?
Which, like.
So you receive federal funding, because you're right, so you fall under some federal guidelines.
Yep.
And you have to meet different things because of them, but you also get funding through the federal government.
So as an FQHC, we get a grant, and that grant is intended to cover the uninsured, and the sliding fee scale and pre-care and other compliance requirements. 'Cause while we are all participants of Blueprint, and we have all of the Blueprint requirements, we have 90+ requirements on top of those for regulatory compliance. So some of that funding goes to stay in compliance with our federal grant recognition.
So I just want to be clear, since we're putting everything on the table, they're getting federal funding, others around this table are not getting federal funding.
Does that change your Medicaid rate? Like when you say it's a 20% increase, is your Medicaid rate as an FQHC different than,
The way that finish your question, sorry.
is your Medicaid rates, how does it compare to the other primary care, I guess,
It's not comparable because
as an FQHC?
yeah,
Okay.
it's hard to, it's not an apples to apples comparison.
It is not an apples to apples comparison.
Yeah, so for that,
See you later.
I know, I know, it's difficult.
Jeez. All right.
so I would add that right now, Vermont Medicaid has not been in compliance with federal law for FQHC payments since the beginning, for the last 2 decades. They tried to fix this in 2017. They have not fixed it. That's why we have that budgeted gap for just our Medicaid care of $15 million. We recognize you have a number of other competing priorities, which is why we had a revised ask of the 6.9.
Melissa?
In your slide deck, you have the actual projected Medicaid costs. So you have what the encounter rate is that you're getting from Medicaid and then your average cost per visit. What are you getting as an encounter rate from commercial, Medicare?
So the commercial is the community fee schedule, so that is paid,
That's
like other primary care.
okay, so you don't have an encounter. And Medicare, same thing?
Medicare is a separate encounter rate specific for our Medicare patients, and that is set nationally with a geographic adjustment based on where you are. So all federally qualified health centers across the country start with the same base, and then it's adjusted based on where they are.
So you're working off of the community fee schedule, you don't have a different fee schedule with, like say Blue Cross Blue Shield, you don't negotiate your own?
We can't, I mean, we're only each organization can negotiate,
Okay.
so there's not.
So you're not able to negotiate together as a,
PP1, PP2.
I'm not familiar with that.
Oh, I thought that was your slide deck, never mind.
No.
So I hear the need. I also see the need of everyone else. We reduce Vermont Care Partners. I'm open to other suggestions for by state.
Could we reduce this some? I mean, is that
Whatever we want.
doable? I mean, it's
Majority wins.
percent increase, could we? I don't know.
Lori, I have a conundrum because if all of, or everybody, like I need help figuring out if the FQHCs are all part of the hub and spoke, this pilot that all of us, almost all of us, agree to invest in
It's
is.
better, Daisy, almost all of us.
I didn't forget about you. Almost all of us agree is worth trying out. It's going to bring in another, 1,100 Medicaid patients per month.
With the funding.
With the funding. Isn't that going to impact the bottom line for these FQHCs as well? So I just, I wonder if this ask also incorporates that anticipated increase and if we can consider that, and I don't know what advice you have about how that might factor in.
Did you want to comment?
Yeah, so I think part of our ask is really what we're asking for is a kind of a bridge funding to get us to where we need to be. And when I say that, we have been engaged with Divas a year ago. We started a year ago with the goal of incorporating and getting us aligned with federal law in this fiscal year. That did not happen. So part of our request is this bridge funding to help FQHCs not have budget deficits for the next year, and then in that time, continue to work with DIVA around establishing a payment methodology that is in alignment with federal law, that we can then make part of the next fiscal 2025. So I just want to make sure that,
Yeah.
and I think part of that payment methodology is thinking about how does a blueprint expansion factor and what are the other factors that need to be considered in a payment methodology aligned with federal law.
So
Got it.
one of the things we could do is put in language that we would have to work on with legislative council to, there's other places we do rate studies. This isn't really a rate study. It's aligning the methodology with federal law. So we could put that in as language to help nudge DIVA to move forward and come back to us with what it would take as a budget ask. And we could offer that offer to keep a rate increase in, but at a reduced amount. Or the whole amount, if that's what people want.
If I may, I'd like to do both. I think we do need a study because it seems very complex and, I'm just looking at the slide of one of your reimbursements over time and it's clearly inadequate. So, and if it, how DIVA and you, the FQHCs have interacted seems unclear on this topic. So I think we need to direct some action on that. So yes, I think and there is there's some language in here, or whatever language makes sense. I would also, 20% I think is something that or more that we can contemplate, but we are thinking about 4% in other places. I'd like to somehow be consistent. I know it's not going to get near what you need, but at least it's something to acknowledge the problem, which I guess is the only thing we could do at this point in a realistic kind of way. So we went to 110% on primary care. I don't know how that fits with the FQHC. I think about 4%, which we did with department. It is primary care. So I don't know how that would calculate out at all. But at least I'd like to be consistent across the system.
Okay.
Lori,
That would be like 1.4 million.
If we went to 110%, 100,
Well, you can't, there's no,
so much apples and oranges.
yeah, exactly.
I get the encounter rate problem.
Right.
And you're doing so much more with your encounter rate as we do for fee for service, and I know we can't.
So what I would say is we look at the number and we say, we're gonna cut it in half, we're gonna cut it by 3/4, we're gonna cut it by 1/4, instead of trying to put it in.
Well, I just took their number, and if you assume it's roughly 20%, using that as a calculation, 4% equivalent, recognizing that's not really 4%, it's like 1.4 million. But I don't think that
All funds or general fund?
all fund, because they're asking for 6.9 gross, so this would be, 20% of that. If you did-
1.4 million total. Or
Yeah, I mean,
or general
and
fund.
again, to the point, like, I don't think it's a real 4%,
You're right, it's a different animal.
So, I mean, it just, if you're trying to find some kind of methodology, it's not that clean, but.
I think we ought to leave it in for now and fool with it as we kind of hone the thing down, maybe.
Well, we have to do it by
Okay,
today.
that's fine.
Right, but
So,
We're gonna revisit all this later and then
Yeah.
kind of squeeze it.
I will put in a plug that I have never been more impressed with how quickly I've received care anywhere in my life as I have been with Community Health Centers Burlington.
all right, let's keep it in. Know it will probably be reduced, and let's start prioritizing.
Well, it's hard to prioritize until we know what we're reducing to. Could you just think about that for a minute? Because, well, for me, it might change. This number is hard. 20% is hard,
Okay,
even though I'd love to do it. But given everything else.
From scratch, no.
no, we're not starting from scratch. I'm gonna have a plan, trust me.
We've all changed our.
I've got a plan.
She's a woman with a plan, you and.
I know it might change, Leslie, but I want to hold off on doing a number there. Okay, so what I have heard as we've talked is that our priorities are really around supporting the prevention pieces of our healthcare system. And pretty much everything that we have in the not governors recommend is doing that. We have reduced some of the numbers. I think FQHCs, I'm going to be honest, will be reduced. We'll just have to figure out by how much. And we're not taking anything out, which is fine. We just now need to prioritize. So,
Specialty care, that what everyone wanted that, is that,
yes,
except me, okay.
yes,
Registers a no.
yep.
I have a question.
Oh, sorry, go ahead, Maureen.
While I was at my appointment, did you have a conversation about the over-the-counter meds?
Yes, the majority voted to reject the removal.
Okay, if I could vote, I would support rejecting the removal with the comment that we have other ways to save the state millions of dollars, and we have the power to do it now. We just need to act on it.
Yep. Okay. So of all of the things that we have on here, I don't really have plans. I'm trying to formulate one while I'm talking. we're gonna start with low. So,
Lauren, can I put something?
yep,
You have a duplication on here, you have EMS twice.
yeah, we're taking out the 80, we're taking out the 80,
We're taking-
yeah. No, we're gonna start with the high. So, so what I have heard around the table is that the highest things by the majority of people are the primary care, specialty care, EMS, home health.
Vermont Care Partners.
Vermont Care Partners.
You didn't hear,
Well, huh?
you didn't hear, clinics,
Free
free
clinics.
clinics?
Yeah, they're going in. That's 450,000. I'm not gonna worry about that. I'm looking at the big dollars.
That's good.
So we can put primary care, specialty care, EMS, care partners, home health, and FQHC. So they're all gonna be high, which I'm okay with, but then we gotta pick 1, 2, and 3.
Primary care, specialty care.
I'm gonna have a suggestion on that.
Okay.
So they're all gonna be high.
Actually-
We just have to go 1, 2, and 3 of our highs?
Yes.
Okay.
Partners.
We're gonna pick 3 of these.
Long-term care.
Right,
Okay.
I know.
and
No,
Or this the
FQHCs.
pain.
Did we say FQHCs are high?
And Vermont Care Partners is at 4%, right?
1, 2. Is the home health,
Try those again?
Sure.
yeah,
It's pretty much everything.
Yeah,
But EMS, the one-time study,
Okay, yeah.
Cetera.
What's the Terra go with?
Cetera is, we haven't talked about that, but that was,
All right, okay, never mind.
I have an idea for that.
Yeah.
that I'm gonna throw out.
and home health, you said?
Yep,
And I'm missing 2 more.
how many are there?
home, primary care, specialty care, EMS, Vermont Care Partners, home health, feisty.
You're not including the study, the 260?
Nope, not yet.
And home health, we're only dealing with the first year or the first 2? You said that we were gonna
Yeah,
put off the.
hold the other.
Top 2, but is that 1?
90%,
Does that count as 1?
yes. Okay.
May I say something? I just want to make sure the committee understands on the 90%, if you did not accept that, you'd be actually reversing your decision from the BAA. That's the continuation of the policy decision made.
Yep.
from the BAA.
That's why it's in the high. Okay, so it is going to be a majority. We're gonna do 1, 2, 3. I'm sorry. Unless someone has another idea, which I'm open to. We're gonna do 1, 2, 3, yes?
Section.
Are we combining, primary care and specialty care together as one request? Or are we counting those as 2 separate?
I think they should be 1.
I do too.
Primary and specialty care?
Yeah,
All right, then that makes 5.
that makes 5.
Well, they're combined into 1, then it's the same number.
You're combining all of the EMS together.
And I'm only taking the 100% of EMS.
Oh, the other one.
And we did with Medicaid rate, we went to 4.
Yep,
Okay, so we're doing 1 through 3, period.
1 through 3.
Okay.
Yes,
I'll go. I would say primary care.
okay,
Is a
Home
1,
health.
is that what you're,
I would say primary care would be 1,
okay,
home health 2,
okay,
and by state, the final one we did would be 3.
okay,
And only because I see all of those as basically primary care.
okay.
Actually, Laura, if you give me 2 minutes, I can create a spreadsheet.
Great.
Give me like 5 minutes.
Okay, all right,
Oh my God, yes.
Thank you.
so while he's doing that, let's go to the governor's recommend.
And just to be clear, we're doing EMS, primary specialty,
Yeah,
home health,
yeah,
FQHC,
yeah,
and Vermont Care Partners.
yeah, should be
Anything else?
5, nope,
Okay.
okay. So when we, let's do that as 1, 2, 3. The governor's recommend, let's do it, let's raise our hands, or do some straw polls. Okay. So dental rate increase. High, medium, or low? All those in favor of high? Okay. And that is both, because the one is just a thing. Drug coverage changes with primary pharmacy benefit. So this is rejecting the proposal. High, medium, or low? All those in favor of high? All those, are you okay, Daisy? Ready to vote?
I want to reject. This one always confuses me.
This is, we're taking it out. We're not accepting this as a proposal.
Yeah, I don't want
Okay,
to.
so that's what high is, the.
No, that we are not accepting it as a proposal. That was the majority vote. Now we're just ranking it with all of the others in his proposal, the governor's proposal of high, medium, or low.
Okay, now,
We can't vote for more than one high?
No, you can vote for as many highs as you want.
Wonderful.
So a high last time everyone voted on, so that's why we didn't go to medium.
Yeah.
so which one are we voting on?
We're voting on the drug coverage changes with pharmacy benefit
Yeah,
to not accept it as the governor's recommend.
okay, so,
That's already been voted on. Now we're saying it's a high priority, a medium priority, or a low priority. We're not there yet. We're here.
oh,
Does that make sense? Okay, high priority to reject it. 2, medium priority to reject it. 5, all right, so that's gonna be medium. All right, now we're gonna go to the eliminate Vermont cost sharing of $500,000. Again, the majority agreed to not accept it as a proposal. Now we're ranking it high, medium, or low as part of the governor's recommend. High. 4, oh, we're gonna have a tie. Medium. Maybe not, medium. Medium. Low. High wins. Don't you love how this is just, so democracy in action. Okay, then our next one on the governor's recommend is the mobile crisis response. Okay, we're gonna come back to that one.
Based on the groaning sound.
Get it done.
Maintain the 988 suicide line. So remember, there's 475,000 in base funding. The line, the calls have increased. This is a vital part of our suicide prevention in this state. So this would be adding more money to the base in order to keep the line going. We agreed to keep it in, so now it's high, medium, or low. All those in favor of high? So that's majority, so I'm going with high. Peer support credentialing. So again, we've already agreed to keep it in by majority. I also want to remind everyone that peer support credentialing helps us as well if we do the mobile crisis response, because by federal guidelines for the mobile crisis response, we need peer counselors. It also will help us with something we haven't heard about yet, which is certified community behavioral health centers, which some of the DAs are doing, which has peers in it. So again, some information we haven't really heard about, but this things. So keeping this as high. Oh, did you have a question?
No, I'm just ready to.
Okay. has a question.
Yeah, I have a
It's
question
timing, yeah.
before we vote.
Sure.
And the reason I hesitate on this, because when we took the testimony, what I heard is not peer counseling. I heard what this says, peer support.
So I'm sorry.
And
Support.
and the distinction I heard from what we heard is the peer, the person with lived experience, so they say, it kind of commiserates with the person with the problem rather than help him fix the problem. And that's why I don't like what I hear about peer support. It didn't sound to me like what they were doing was helping, is more hearing the person out. And I think personally that we hear them out too much. I think they need to be helped and told what to do and set on a path that'll get them fixed. So that's why that's the distinction I make.
All right, so I'm just gonna say that peer support in some circumstances is really vital to someone's treatment and health. So I'm just gonna leave it at that and that you vote as you want. Okay,
Ready, Lori?
all right, hold on. High, medium, or high on peer support credentialing. Okay. Therapeutic alternatives. To the ED high, I think everyone knows this. Okay. I know Woody would be very proud of us. Mobile crisis response. High, medium, or low?
High.
High. Mobile crisis. Okay, let everyone take another minute to think.
So we're going
With
back up to that. If we
modifications,
just-
can I modify my high and say with some language modifications or?
I don't think we can modify this with language because they're still working through the contract. I mean, it's an RFP that went out. It's going to be a contract. We can ask for reports back.
Yeah, I'm not into requiring reports.
I mean, we're going to hear testimony anyway.
Yeah.
I've changed my mind, so if you want to take the vote again.
What did you say?
She's changed her mind if I want to take the vote again. Is everyone ready?
Yeah.
Hi,
What are we voting? Mobile response, right?
mobile
Mobile
response.
request.
I changed my mind.
Okay.
General fund dollars.
Okay, emergent and exigent circumstances impacting healthcare providers. I would like to make a suggestion. Satara House and the one-time funding for EMS, I think should be the one-time study, the $100,000 for a study in the Satara House. I would like to put them in our budget letter, and if appropriations needs money to do those, to take it from this $10 million fund. But I prefer that they don't take it, but if they needed to, that would be a way to get that in.
And leaving out the reimbursement,
No, that's in,
the rate, that's
that's
it.
in, yes.
Are we still in the governor's?
We are, so we're in the one-time money, the $10 million, right? So we just need to say high, medium, or low.
On the emergent,
Yep. So let's do that first, and then I'll go back to the other suggestion.
Nolan, can they do that if this is kicked down from ARPA dollars? Can they use that for capital investments?
This is general fund dollars.
Okay.
General fund dollars,
The 10 million is general fund, right? Yeah,
so it says.
so I don't think, so I'm not sure where the ARPA.
yeah, there's no,
I thought you said it kicked down from,
No, I was saying that I think because we had federal dollars, it freed up general fund.
okay.
That's one of it.
it's general fund dollars, so we could do it if we wanted to. All right, so let's just put this one, $10 million, one-time funding for emergent circumstances. High,
I'll go high with the language that,
let's do separate.
okay.
High, medium, medium.
Wait,
Okay. Let's come back to that. And then, blueprint. We agreed to put it in, so high, medium, or low.
Which one?
Blueprint. High. High wins. Okay. So we now have all of our highs, a couple of mediums. So we're gonna do 1, 2, 3 on the non-government recommend and 1, 2, 3 on the governor recommend.
So before you do that,
Yeah.
there's 2 ways we can do this
Okay,
to weight it.
okay,
Either everybody gives me their top 3 and I just assign a 1 to each of them.
okay,
Or you give me your 1, 2, and 3, and I give your top priority 3, your middle priority 2.
We
your
did
middle
voting.
priority 1, and that's, so we could come up with a totally different result. But they're trying to how you weight
right.
stuff.
So say that again?
So either,
Yeah.
everybody can give me, this is the fair, trying to think of the fairest way to
Yes.
do it. Everybody give me your top 3 and I assign each of them a 1.
Okay,
And then we can see which gets
Has the
highest.
most ones.
And then you can, and if there's a tie, you can do your, or you give me 3, 2, 1, and your highest priority gets a 3, your lowest, middle gets 2, and your low gets a 1, and then we see which one is weighted the
has
most.
the most points.
So it's up to you, there's 2 different methodologies, but they might come different results, that's why I have to lay it out for you.
I like the first choice.
Top 3? Everybody gets 1, 1, 1,
Yep,
okay,
1, 1, 1.
and then we can see how it sugars out.
I like the second choice.
You like to rank choice?
Ranked choice voting.
Ranked choice voting? What do you rank choice voting?
All right, everyone in favor of the first one, 1, 1, 1, raise your hand.
Making more decisions.
Decision fatigue.
Yeah.
I agree.
Rank your
But we're
choice.
really
Which
close
choice?
to do this part and then come back with the clean data to look at. So let's
Let's choose.
boogie through this.
So could we get maybe you have this, what's the list of our highs that we could just get high on? Can you, sorry, it had to happen, right?
Let's listen.
It's EMS, primary specialty care, home health, F2HCs, Vermont Care Partners. And which is DA, I'm just lumping them into a category.
Sorry, home health, FQHC
So hard.
and partners.
So tough.
All right, we're gonna do 1, 1, 1.
Okay.
There you go.
What?
Egalitarian.
So EMS, primary specialty care, home health, FQHC and partners?
Are we supposed to be doing something right now?
Yes.
Yep. So whoever wants to start is going to
Let
give,
us think for a minute
Yeah,
here.
you can tell me your top 3.
I'll go first.
you know what?
I'll
Wait,
go first.
now I'm getting it. No, we're gonna go back the other way.
You understand?
Now I understand.
That's better.
Yes,
Okay,
yes.
okay, right
Doing
choice
a
voting.
great job.
Yes.
That's all I know.
So 1, 2, 3. 3 is your highest priority, 2 is your second, 1 is your least.
Yeah.
Okay,
Just tell me your highest, middle, low.
Right.
So you say 1, 2, 3, then I'll get confused.
yeah, so high, middle,
Your high, middle, low.
low. Alyssa's gonna start, so she will, you can follow.
Number 1 is not your top choice.
Right, so give it in order. Don't even give a number. Say your top choice, your second choice, your third choice.
Yes,
Okay,
Alyssa,
my top choice is primary care and specialty care.
okay.
My second choice, my middle choice is EMS.
Okay.
And my third choice is home health.
Okay.
I'll go next.
Topper.
My first choice is home health. My second choice is primary care. And my third choice is Vermont Care Partners.
So can I ask a question? They're all saying 1, 2, 3, and we agreed that is 1 your first choice?
No. So whatever your first choice is, just say
Number
that.
Okay.
Just
Tell me
say,
in order.
just say your order. Your first choice is,
You want to do that now?
if you're ready, if not, I can go.
Okay, no, I got home health, EMS, and primary care.
Home health. Home health. Okay.
Again, remember, these are all high, right? So they're all gonna stay in. It's just a matter of how we're ranking them for appropriations, which may or may not matter to them. Who wants to go next? Bobby?
I'll go next. The top choice, EMS, second, Vermont Care Partners, third, primary care, specialty care.
Okay.
Not easy.
I struggle with that.
I'll go next. My top choice was primary care. Second choice is home health. And third choice is by state care.
Leslie, you ready?
Yeah, sure. My first choice is primary care, second EMS, and third is partners.
Is what?
Partners. We have to do partners.
Vermont Care Partners.
Yeah.
You had your chance.
No, I was just confused because of what you said is, we already did it in the first half of the year. How do we not do it in the second half of the year?
You're talking about home health, not Vermont Care Partners.
Okay, I'm sorry. You're right. I did.
So what are your,
Partners.
oh, okay.
I got confused.
So hold on. So for you, I have primary care, EMS, partners.
Yes,
Okay,
thank you.
easy.
Are you ready or you want me to go?
You can go.
So I have EMS, primary care, and home health.
Okay, Daisy.
Vermont Care Partners, primary care, and home health.
Okay. Only people in the room?
Only people in the room.
Okay. So
Unfortunately.
first with 17 is primary care. Second with 12 is EMS. Third is home health. 11, fourth is Vermont Care Partners, and the fifth is FQHC.
Okay. So we're gonna say our highest priority is primary care, our
Primary
second,
specialty.
primary care and specialty, our second is EMS, and our third is home health. Did I get that right? Okay. Okay, so primary care, home health, primary care and specialty care is our top.
Yeah.
EMS, 10% is our second, and home health is our third. The rest are still high. Okay. Do you guys mind going for 5 more minutes? Or do you want to come back?
No, you mean then we'll be done?
You know what, let's come back.
We might not be done.
We won't be done.